Hi, this is Dr. Bob, Bob Dannenhoffer, the Public Health Officer for Douglas County, with another of our Facebook Live events. It's April the 16th today, and we're doing this. It's actually gorgeous weather outside, so I hope people are not staying inside listening to me, but get outside, get some sunlight, and get some exercise, two things we've had not enough of in the last few weeks. Anyway, this is a chance for us to review what's happening in the world with COVID, and then I'll answer your questions. And then please put questions in the chat section, and we'll answer those. And we'll answer those. So we already have some questions in the Facebook questions at douglaspublichealthnetwork.org, and we'll get to those first. But we have plenty of time today if you have other questions to do. Let me go over the world here. Well, starting at the world level, clearly the world is in a fourth peak of disease. The level of disease in the world now is every bit as high as it was over the Christmas holidays, where it peaked. It then came down quite a bit, came down by as much as a half, but it's right back up to where it was before and rising very quickly, which is really quite worrisome. Disease is very prominent in Turkey, France, Sweden, in South America, especially Brazil, Argentina, and Uruguay. And then we're starting to see a lot of cases in India. In India has been an enormous area of concern, a very populous nation, very densely populated in many areas. And in India, there's this double variant that has two of the most worrisome mutations combined. And what we worry about is that when you combine those two, it's going to spread a lot. In the U.S., we're at 31.5 million cases. We had 74,000, averaging 74,000 cases a day. So remember, we were down in the low 50s, and now we're in the mid 70s. Very, very active in Michigan, Minnesota, Texas, Panhandle, Florida, New York, New Jersey, Pennsylvania, and Rhode Island. And when you look at those areas, many of those have the B.1.1.7 variant, the UK variant, which seems to be much more contagious. When we look in the U.S. overall, our number of cases are up. The number of hospitalizations, which is the most predictable number, are up. And the number of deaths, which have been coming down for weeks at a time, is now flat and maybe starting to rise. So this is a big worry. In Oregon, clearly the number of cases are up. Our number of hospitalizations is up a little bit. Our number of deaths remains low, but we're certainly seeing more disease in Oregon. Certainly the Tri-County area, pretty much all of the I-5 area except Douglas County. And the eastern part of Oregon, which in the past had not had a lot of disease, is now starting to see disease in like Baker County and in Klamath County. Douglas County, we're very flat. Actually, we're down a little bit. We are very close to moving from the high range to the moderate range. To get from the high range to the moderate range, we need less than 112 cases over a 2-week period. We're at 106. So it depends upon how many cases we get in the next 36 hours to see if we'll go up or down. It's about a coin toss at this point. But we would be one of the few areas of the state that are going down while much of the rest of the state is coming up. In terms of the vaccine, the big news this week has been about the J&J vaccine. I see we have some questions there, and we'll go ahead and get that. And the other thing that we want to talk about is testing. There's still a lot of testing out there. So again, anybody who has symptoms suggestive of COVID really should get a test. The Binax Now tests are very inexpensive. They're fast and very accurate. So there's no reason not to get a test if you have symptoms of COVID. All right, let's get to our questions here. So Bruce says, I'm confused. I heard you say there were no safety signals related to the J&J vaccine. And now we hear the technology is the same as the AstraZeneca that has a lot of safety signals. So I said that as of last Tuesday, there were no safety signals associated with the J&J vaccine. These were first reported on Thursday and Friday, and I said that on Friday that there were some safety signals. And then on Tuesday of this week, they paused the use of this vaccine. So the story is there were no safety signals associated with the J&J vaccine. Now the J&J vaccine is a human adenoviral vaccine. The AstraZeneca is a chimpanzee adenoviral vaccine. They're related in that way, but there were no safety signals associated with the J&J vaccine. So I'll stand by what I said. So it comes out that one of the trial participants died from a blood clot. So if you take 20,000 people are going to die of a blood clot. And so that's I don't think, I wasn't privy to the exact data that was there, but that doesn't sound like anything that was a safety signal that shouldn't have allowed approval of this vaccine. Now, what you're seeing on this is these are unusual blood clots, probably because they're following an unusual mechanism, which is this platelet factor 4 activation. And so it's a rare thing. And still, even this week where everybody's been clearly looking for these cases, we've only added a few more. So it's still a very, very, very rare side effect. Now, serious when it occurs, but a rare side effect. And when you consider how effective the vaccines and how bad COVID is, still the benefits clearly outweigh the risks. Now, I'm sure we're going to come up with some decision in the next few weeks about what we do. It may be to continue the J&J vaccine with no restrictions. It may be to totally halt the use of J&J vaccine because we have other vaccines that don't have these safety signals, or there may be something in between. And I'm not privy to the internal negotiation, so I don't know how it's going to come out. And I will tell you that the disease itself, COVID itself, causes lots of clotting issues. And so the risk of clotting and having very severe clots from COVID is there too. So this is a tough one. I have really good sense that we have our best scientists in the country working on this, that they have all the data that they need, and I really trust the great scientists to come up with a good answer. And I don't know what that is. I don't have all the information at this point. The big concern is that people can say, ooh, I'm worried about the side effects. I don't think I'll get the vaccine, and our rate of vaccine uptake will decrease. Again, to really stop this from spreading, we're going to need to get 60, 70, 80% of the people immune. And right now, only about 5 or 6% are immune from previous disease in Douglas County. And only 21 or 22,000 are fully vaccinated from the vaccine. So we're only at 25% or so, which is not enough to keep this from spreading. Now, it will definitely decrease the number of cases, and we've already seen that, and it will decrease the size of the outbreaks. We've already seen that, but it's not going to get it down to a level where we can get rid of masks, we can get rid of all the other restrictions, and that's really our goal. So Tracy says, please talk about breakthrough cases. So breakthrough cases are those cases where somebody is fully vaccinated, that is 2 weeks from their J&J vaccine, or 2 weeks after their second Pfizer or their second Moderna vaccine, and then they come up with the illness. There have been in Douglas County around 10, in the state about 168, and in the country they said about 5,800. Now, you'd say, well, that number in Douglas County looks higher, and I think it's because we're really looking at it carefully, but the numbers are not very big. There are 75 million fully vaccinated people. So 5,800 cases out of 75 million vaccinated means that the vaccine has great efficacy. And that's what we've seen here. So we have cases at a workplace, 4 cases in the workplace. All the people who were not vaccinated are the ones who have the disease. People who are vaccinated are contacts, but they don't get the disease. So it really does look like the vaccine is going to be 90+% effective. Not 100%, but 90+% effective. That's a pretty darn good vaccine. So Dee Dee says, where do I report symptoms or side effects from the J&J vaccine? So if they are unusual side effects, so if you were tired, had an achy arm, there is a patient reporting system that is on the bottom of the sheet that you got on your EUA. But if not, we'll get you the place to report that. If it's an unusual side effect, a blood clot, something that required more, something that was not the expected side effects, we do want to hear about that. And you should talk about your provider, and they will submit that on a system called the VAERS system, the Vaccine Adverse Events Reporting System. And that's how we found about these clotting things, because they were submitted on the VAERS system. It really works. So again, if it's one of the expected side effects, you can report it on the patient portal. If it is one of the other ones, it should get reported on the VAERS system. Has there been an outbreak at Clint Newell this week? Not that I know of. Clint Newell's got a lot of other things, but we didn't see that. So Michael said, comments from yesterday's county bulletin seem to focus on churches. I think it did. it seemed that it was based on one current outbreak of 15. So there is one current outbreak of at least 15, and that's what was mentioned there. There have been lots of other outbreaks in the past. So there have been a number of other large church outbreaks that have resulted in hospitalizations and deaths. And so this one came up because we're at the end of a year and we're doing a year in review, and came up with church. Are there other current outbreaks linked to churches? So there have been in the last month other current outbreaks linked to churches, but right now our number of cases is getting low. The number of cases related to anything is decreasing, thank goodness. But churches are a worrisome area. You bring a lot of people together. They're typically from maybe different parts of the community or even different parts of the county. So if there's one person who's brewing the disease, asymptomatic, gets together, they can now spread it out across the county. So as I said, there's one current outbreak. There are two others that are ending, but it's just this one current outbreak, and it was part of our time to do our year in review. Okay, well, we've got a bunch of other things here while we're getting questions. So question that's come up again and again is, whether we need a booster to this vaccine. The answer is, I don't know. It's possible. Certainly with the flu virus that mutates fairly quickly, you do need a booster every year because the disease that spreads changes enough that the vaccine that you had from the year before doesn't really help you very much. And the antibodies from the flu vaccine drop off after 6 or 8 months, and so that's why you need a booster. In this one, we don't know if the antibody levels will drop off. At 6 or 7 months, the antibody levels still look pretty darn good, and we don't know if the virus is going to change enough that you're going to need a separate booster. But I think both Pfizer and Moderna are planning that you might, and so they're coming up with a vaccine that could be used as a booster that would not only boost your immunity to the original one, but would also boost your immunity to the variants. And I think that's a very good thing to do. I mean, if you needed to get a booster once a year, that wouldn't be such a big deal. People get flu shots every year, and we have kind of incorporated that into our usual flow of events. So let's talk a little bit more about the variants. This week I spent much time learning about the variants. And so again, we started off with the original virus. I think they're calling that B1. And what you see on that is that was one with no mutations. Early on, even last summer, we started having the one mutation, which is the D614G variation, that made it perhaps slightly more contagious by taking that spike protein, which in the past had a place on it where it frequently broke. Think about a stick that is scored, that if you bend it, it's going to break there. And that scoring area caused the spike protein to break and become not effective. And this D614G change made it stronger at that area. What's happened now is that the D614G variant is there in almost every virus you look at now. So it went from not being there at all in the spring of last year to the spring of this year. It's there in almost every one of them. The B117 variant showed up mostly in November, December of last year. And in many places, especially in Europe, it went from not being there in September to being the only one that's there now. And so what happens is these variants become the dominant form and then very quickly become the only form that you see. And this B117 is worrisome because it's much more contagious. There's still question about whether it's more deadly, but it's clearly much more contagious. And when you look at the big outbreaks in Europe and the big outbreaks in Michigan and Rhode Island, these seem to be mostly related to the 117. There's the Southern California variants, which are a different part of the genome, and these seem to cause the disease to be a little bit more transmissible. But they don't spread in a population nearly as fast as the B117, which seems to spread very quickly over the space of just a few weeks. It goes from being first detected to be the predominant form, and that's very worrying because if you look in this country, There are places in this country where we're having a lot of disease, like Michigan and Rhode Island, and it seems mostly to be related to this B117 variant. Now, there are other places in the country that aren't having a lot of disease. Kansas, Arkansas, Missouri aren't having much disease. That's mostly because the B117 hasn't really arrived yet. And the worry is that Michigan's going to go through this terrible time. They'll kind of get over it, but then you're going to see another conflagration blazing in Arkansas and Kansas when this shows up there. So Carolyn says, a hypothetical, if you had the J&J vaccine months from now, booster for variants are available for Pfizer and Moderna, can you have those or will you have to stay with J&J? That's a question I do not know the answer to. You probably don't need to stay with the original one. Typically, when you get boosters of anything else, you can switch to a booster of a different virus, of a different maker, but we don't know the answer to that. So Casey says, do you feel that it'll be safe enough to visit family in Minnesota in August, assuming all the adults who we are visiting are vaccinated, but our children are not? So according to the new CDC guidelines, for people who are fully vaccinated, they can visit low-risk unvaccinated people, like your grandchildren, if they're low risk, and that would be acceptably safe. So if your grandchildren are low risk, then you can visit them. So Cheryl says, with the new nice weather coming, do you think we'll see new cases spike? We don't know. So, predicting is hard, especially when you have to predict the future. The Oregon model suggests we're going to continue to have a rise in cases for at least the next 6 weeks. And so that's as the weather gets nicer, we'll see a spike in cases. And much of the rest of Oregon is seeing a spike in cases. Douglas County not. We've been low, which is great. Keep it that way. Do you think we'll use CDC guidelines for summer activities? Yes. But remember, guidelines for outdoor activities are much less restrictive than guidelines for indoor activities. And so, for example, I hear that the music on the half shell is maybe a go this year. That's probably going to be fine. It's outdoors. It's usually breezy. So excellent air circulation. People put their blankets out. Usually just because of the way the blankets sit, you're 6 feet away from somebody else. And so I think those things are going to be pretty safe. We've talked about the fair. Again, many of the outdoor activities in the fair should be plenty safe. And so don't really know. So Judy said, at which point can the current vaccines lose their experimental status? I don't know. This has been all the rage this week about getting away from EUA to full approval. In terms of the approval process, it really does not make much difference. By being in the experimental status, it gives those people who give the vaccine, those people who make the vaccine, protection from liability, and provides compensation for people who get the vaccine who are injured. And so I don't know when the FDA is going to move from the EUA to full status, but really in terms of whether or not you should get the vaccine and whatever, some people made a big deal about this, but it really doesn't make a difference. One of the things that comes up is about blood types being a risk factor, and we've seen over the years some people suggest that they are a risk factor and then others not. This study that came from the U.S. that looked at a lot of people, it was in a health system that had all of their blood types, and it showed that blood types were probably not a risk. So we have a little bit of data that's suggesting it is a risk and some that's suggesting it's not. In any case, it is not a huge risk factor. So there are some things that are a huge risk factor. Age is clearly, far and away, the biggest risk factor. So at every age group, as you go from 50 to 60 to 70 to 80, every time you're 10 years older, it's at least 3 times more likely to die of COVID than before. So if you take the lowest risk, being somebody who's 20, by the time you get to be 80, it's 8,000 times more likely to die at 80 than it is at 20. So age is far and away the biggest risk factor. So, when we looked at what the risks were, and clearly the best way to do this was by age. Now, you could add other kind of things that might add to your risk factor. So a 50-year-old with blood type whatever was this much more risk, it would give you a difference of a few weeks of difference. Not nearly the same kind of difference as it is for age. So this study suggested blood type was not a risk. And again, since you can't really do much to change your blood type, it's interesting but not really important. The other ones that came up as we continue to look at things that might help or not help for people who are early on in the disease. Remember, we went through a long time with hydroxychloroquine. Again, another study came out this week suggesting hydroxychloroquine doesn't work. So when you look at all of the good studies, there's not a single one that suggests that hydroxychloroquine works. Ivermectin is more confusing because there's sort of scattered data out there, but a very good study that came in with ivermectin in the last week suggests that ivermectin also doesn't work. In any case, if it works, it's clearly not a miracle drug. We have these monoclonal and polyclonal antibodies. They do seem to work, and they do seem to reduce your risk of hospitalization or severe disease by about 2/3. So the monoclonal and polyclonal antibodies do work. Not magic, but they do work. And then there was a new one that came out this week about inhaled budestonite. So budestonite is a steroid, very safe. We use it in young kids, and it does seem to be somewhat helpful in reducing the risk of severe disease. And so if people want to, and it's very safe. So if people want to use inhaled budestonite, I have no problems with that. So Ann says, do you think we'll need a booster after 6 months or a year? I have no question about that. No idea about that. It does not appear that you'll need it after 6 months, because after 6 months, the antibody levels are still high. The protection still seems to be high. If there's going to be a booster, it might be every year, but it might be every 5 years. I mean, the antibody levels may be good enough that you don't need a booster for 5 years. So for example, with tetanus, you get really good antibody levels. And so you don't need a booster of tetanus more than every 10 years. And so it may be a year, 2 years, 5 years. I don't know. But the only way we're going to know that is by following the disease over the next months to see those early immunized people if they start having more and more breakthrough cases. So one of the things that we have done along the way is we've looked at our doppelganger counties. Again, these are counties. These are 3 other counties around the country that are similar to Douglas County in that they're about 100,000 people, that they're not big urban centers, they're near an interstate, they have a mixed population base and a mixed economy. And so we've picked Douglas County in Oregon, Twin Falls County in Idaho, Pennington County in South Dakota, where Rapid City, South Dakota is, and Lowndes County in Georgia, where Valdosta is. So when you look at them, the counties are not exactly the same, but they're close, and that's why we call them doppelgangers. And so we looked last week at the death rates, and again, Douglas County was about 1/3 of the death rate of the others. And then this week we're looking at case counts per 100,000. So case counts, so new cases per day per 100,000 averaged over the last week. Douglas County is averaging 6.8, so that's pretty good. Twin Falls 14, Pennington 13, and Lowndes 9.4. So all relatively low. Again, Douglas County the lowest of all of those. Other thing we've looked at is early on, you may remember that Sweden was considered to be a model. So Sweden, if you remember your map here, there is Finland, which is more east, Sweden in the middle, and then Norway, which is on the Atlantic coast. Sweden is about twice as many people as Norway and Finland combined. Norway and Finland took what we consider to be the European approach with shutdowns, mask mandates, and whatever else. And Sweden took the let's just see what happens. The idea being that people would have disease early, and then they would see much less disease later on. And so one of the theories was just let this blow through, let young and otherwise healthy people get the disease. They'll build up some immunity in the population, and then we may suffer in the first few months, but then after that, we're going to be fine. And overall, we're going to have fewer cases and lower death rate. So what happened? So now Sweden has 60 cases per 100,000. Remember, Douglas County is 6. 60 cases per 100,000. Finland has 6. Norway has 11 per 100,000. So this idea that we could build up enough herd immunity that people are not going to be able to not get it later on didn't work. And the reason it didn't work is because although a lot of people have the disease, about 10% of the about 10% of the population had disease. That's not enough for herd immunity. And so they have had now 10 times. So Sweden's having 10 times as much disease as Finland and 5 times as much as Norway. And then overall, the deaths, Sweden has 135 deaths per 100,000. So they had a lot of deaths early on, but they continue to have a lot of deaths, where Norway and Finland are at 13 and 16. So this idea that early on, don't really need to do anything, just let the young and healthy get this disease, and then that's how we'll protect the others, really, really, really hasn't worked in Sweden. And Sweden is really, really struggling. So Chad says, when the vaccine is available to anyone who wants it starting Monday, so starting Monday, everyone 16 and above is available. And so we're encouraging everybody 16 and above to get the vaccine. There's no longer any of this staging or phasing or grouping. Everyone 16 and above should get this. How long do you expect it to take to get everyone who wants it to get fully vaccinated? Where do you see the percentage of willing people landing? So again, we're right now about 20 some odd percent of the population has been vaccinated. It's probably a little more than the state numbers because we still don't have the federal numbers from the VA and the Indian tribes, but we're probably around 20, maybe 25% of the people who are currently vaccinated. We think that about at least 50 or 60% of the people will want it, and so we're going to bring that up. But vaccine hesitancy, the number of people wanting the disease, varies widely. In some places, it's as high as 80%. In some places, as low as 30%. Douglas County is going to be somewhere in the middle. So depending upon how many people want the vaccine, we might be able to get up to 50 or so percent by Memorial Day. Now, with the J&J not being used to decrease the amount of vaccine we have, but we'll see. Where do I see the percentage of people landing? I don't really know. Areas that are rural, areas that are less racially diverse, areas that voted for Trump are likely to have lower amounts of disease as compared to more urban areas and places that voted for Biden. So I don't know where the number is going to be. I would hope that the number is going to be high, but again, I have no clue where it's going to be. Some of it will come also out with what happens with this J&J thing. If it's a week pause or a 2-week pause, and we decide, hey, this is safe, we can go back and do it, that may be a problem. If, however, we start seeing side effects from the Moderna or the Pfizer, or the J&J thing gets even more complicated, we may be lower. So we'll see. So what is my take on the J&J vaccine? Well, my take on the J&J vaccine, it is a remarkably safe and effective vaccine. So it looks like about 1 in a million people who take this will have one of these clotting issues. Now, 1 in a million is very low. I mean, I tell you, if you look at diseases, drugs that we use all the time, any of these things on TV, Viagra, birth control pills, antibiotics, all of them have far higher death rates than far higher complication rates than 1 in a million. So I think this is a remarkably safe and effective vaccine. Now, what are we going to do with this? Who knows? As I said before, the CDC may decide that we have 2 other safe and effective vaccines that will get to vaccination without the J&J and not use it at all. I think that would be a shame because given the amount of disease in the country, even delaying reaching more people with vaccinations by 2 or 3 weeks is going to cost a lot more deaths than using the J&J. Or if stopping it at all, it's going to delay this, or delaying for much longer is going to delay the time that we get there. They might decide that this vaccine is out there and it's people's choice. They should get the vaccine they want. Still, even with the new reports on the J&J, we've had more desire for the J&J vaccine than the Moderna and the Pfizer. So it may be you have your choice, get one of the vaccines, and just the choice will be that people will want the J&J vaccine. Or what they may do is they may limit it to certain groups. Again, Almost all of these cases have been women. Almost all of these cases have been people less than 50. So for me, a 65-year-old male, the risk is pretty darn low. And so you might say that this vaccine is best used in the older, more male population. So I don't know where it's going to come up. It'd be a shame to lose this vaccine from the armamentarian because, again, the number of cases and deaths that can be avoided with the vaccine are great. The number of deaths related to the vaccine side effects is relatively low. Now, in all of these things, in every one of these things, they're all just statistics. And if your family is the one who had the side effect from it, or if your family has someone who can't get the vaccine because there's not enough out there and your loved one dies, it's 100% for you. And so you have to be really careful with these statistics. People throw around a lot of statistics, but what you know in medicine, statistics are just that. The diseases are all or nothing. And so you say, well, the risk of this rare genetic thing is only 1 in a million. But if it's your kid who has it, it's your kid that has it. It's not your kid has a millionth of it. Your kid has it totally. And so I'm very aware of statistics being just statistics. We don't live life in statistics. We live life one by one. So Josh says, can you explain how we track the vaccine per person? Is it just by the immunization card or is there a central database? So there are 2 central databases. The immunization cards are just that. I mean, anybody could print one up and sign it. And the fact that we're still using handwritten vaccination cards in 2021 is like, oh my God, really? 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 We don't have a better way to do this, but we still are doing those immunization cards. But there is also a central database. In Oregon, the central database is called the Alert System. It is a great system that I've actually been working on since the early 90s. And you remember, for those of you old enough, can remember the early 90s is at a time when we didn't have a lot of electronic records, when transferring a file across the internet was slow, when email was limited to just a few characters, and if you wanted to send 1,000, if you wanted to send a 5 kilobyte file, it took forever. So we've been starting back then. Right now the system is great. It records all of the immunizations in Oregon. It's stored and backed up. It's very secure. It is a great, great, great system. And so every vaccine given in Oregon by an Oregon provider is in that system. In addition, the CDC has a system which collects the data from all of the states. So the alert data goes into the CDC system. And so that's in that system. In addition, there are 2 big providers of vaccine in Douglas County, the VA and the Cow Creek Tribe, who submit their data directly to the CDC. The big issue on this is that it's not coming back as it should. And I have been working with everybody who will listen, and people are starting to not listen anymore because they're tired of me saying it, to see if we can get the data back from the CDC so we know it. So just today we had somebody who said, well, they got their first dose at one of those federal places. Now they want to get their second dose, but we don't know when they got their first dose because the CDC system is not good about providing data back to us. So it really is a big problem. But for the 99% of people in Oregon who get their vaccines in Oregon, it is going to be an alert system. In Douglas County, we think it's about 90% because we happen to have, for the size of our county, a very large VA and a very large federal tribe. So your question is it just by immunization card or is there a central database? There are 2 central databases, both of which work well. They don't work well talking to each other, but they do work well. Okay, well, we have a few more things here. Taking about breakthroughs, again, the Fed suggested that the number of breakthrough cases was very low. But again, I think they did use misleading statistics. They said only 5,800 out of 70 some odd million people had a breakthrough case, and they calculated a breakthrough rate. Well, really what you need to do is you need to look at the rate of disease among the vaccinated people and compare it with the disease of unvaccinated people, right? Because certainly not 100% of the unvaccinated people got the disease. Probably in the time frame, only 1% did, which still means that the vaccine is over 90% effective. But I think the data that people have been throwing out there is a little bit misleading. Now, when we do it, and we talk about our breakthrough cases versus our other cases, we actually look at the vaccinated and the unvaccinated. And when we do, it really looks like the vaccine is 90% effective. So it is effective, but this 99.99 thing that they were throwing around today is really misleading. And whoever said that should go back to statistics class. One of the questions is, will we go to moderate? Again, for us, the way we determine the risk level is, the risk level is measured over a 2-week period, starting Sunday at midnight and going to Saturday at 11:59. And so it's that time. And so we are nearing the end of that 2-week period. When I looked today, we were at 100 and we use slightly different numbers, but it's going to be close. We were at, as of today, we were at 109, and if we're at 112, so we have, if we have less than 3 cases tomorrow, we're likely to be there. 3 to 5, it's going to depend upon exactly what hour of the day they come in. So we're very close. Now, in the past, we've been very close between the 100 and 200 mark. We're now we're at half that rate. So we're doing great in Douglas County, and thanks to all the people who've helped us along the way. And there really are a lot of people who've helped us with this. So I was asked this week to go ahead and give a presentation at the state about what we've learned from this pandemic and how we should change things in the future for this pandemic. And one is that you have to have the right people in the room. And so one of the things that's been remarkable, Douglas County is small enough that I can kind of know the heads of each of the clinics and the head of the hospital and the commissioners and all of those people, but not so small that it's just me doing all the work. And so what we've been able to do during this pandemic is really reach out to all of those people, and every one of them has helped us in a small but absolutely crucial way. So Umpqua Valley Ambulance, which is one of the local ambulance services, has taken on the lead for testing people in places where they're hard to get tested. So we have some of these people so enormous that they can't leave their house. They go in the house to do the test. Nursing homes that can't quite do the testing, they'll go into the nursing homes and do the testing. Umpqua Valley Ambulance has also agreed to go ahead and do immunizations for people who can't leave the house. So that's just a small part that you probably haven't heard about, but they're doing it. And then we look at, for example, the tribe. So the tribe was able to, the Cow Creek tribe was able to get the some of the testing materials before anybody else was. And it's just this weird federal thing. But they were able to get, for example, Abbott ID Now testing before anybody else was. And they've been able to provide testing, especially rapid testing, for people who needed it before we had the Binax. And again, I don't know if people know that, but they were great at doing that. Aviva has been incredible help. They're the ones who have the cold storage in the community. So they're the ones who've been doing the cold storage. The CCO has been helping us with people who are released from the state prisons and need a second dose. They've been helping us with that. They've been helping us by providing transportation for people who don't have cars and need to get to one of the drive-through events. So they either using one of their non-emergency transportation or using one of the cab services have gotten people to the events. The county has helped in so many ways. Not only are they providing a lot of money, but they're providing a lot of support on other things. So, for example, our Tiger team, which is going out there, the county bought some vans so that they have places to go. They have vans to drive out to these events to do. They've provided so much support at our drive-through events by providing traffic support and others. So the state asked me to write up, what went right, what went wrong, what should we learn from this? And one was, you really need to know these people and work with these people before the pandemic. You can't really expect to form trusting relationships during a crisis, you really need to have this before. And I think that's one of the reasons that Douglas County has worked well. I'm on calls all day with these people who are in bigger counties, and they say, just so complicated. There's no way I can know all the hospital leaders. There's no way I can know all the clinic leaders. It's just too big in Multnomah County. Or other areas saying, this person is fighting with this person, so we could never have them in the same room or on the same call because everybody's fighting. But remarkably here, we have done incredibly well with that. Some of the other learnings that we've had is that many state systems are pretty rigid. State and federal systems are pretty rigid, and they either know two things: nitpicky rules or no rules. So early on during this pandemic, we needed more testing. And the feds were incredibly nitpicky with getting a new test approved. And so for the first 3 months of this pandemic, where it was clear that we were going to need testing, they followed the old rules that they'd followed before. So if you were trying to get a new test on the market, it would be a 2 or 3 year process where everything would be nitpicked. And the answer is, well, if we're going to wait 2 or 3 years to get these things on the market, we're not going to have the testing. And so there was, if you remember, back in February and March, there was this tremendous concern that we weren't having any testing. So then they decided in April, okay, we're going to get rid of all the rules. And then when they got rid of all the rules, a lot of really crappy tests came on the market. And so the goal in regulation was not to go ahead and be so nitpicky that it's going to take 2 or 3 years, but also not to be so hands-off that crappy tests would get on the market in a week. And so we in government and we as a society need to figure out that maybe you don't need the strict rules that you had before, but you clearly need some rules. What's the best way to go ahead and find that? And I really think that that's one of the places that we as a society didn't do as well as we could. I think the other one is that our demand for the data every minute of the time was problematic. And it was problematic because as people were following new cases or new side effects like we're seeing now, people are putting a tremendous amount of heartache into 1 or 2 cases or this or that. And the answer is that some of these things do take a little bit of time to develop, and our 24/7 news culture really suggests that you have to know the right answer by tomorrow, and science just does not work that way. And the other thing that I'd said was there was a lot of politicization. So if one person said something or somebody else said it, you took it with a different way, and that has made this this whole pandemic incredibly hard. Sadly, I did not have an answer for that one. Okay, last chance for questions. It's a beautiful Friday afternoon. Hopefully people are getting ready to go. So one of the things that we do note is that there is this testing available with the Binax. We've tested now somebody down to as low as 8 months to well over 90 years. So again, this new testing does seem to work great. It's provided free to the providers, so there's not a big cost for this test, and it really seems to work very well. Now the Binax was one that was made by a big company, a very good test. But unfortunately, early on when they wanted to do this test, they met all of these hurdles. Then when they got rid of basically any restrictions, that other crappy test came out the market and really hurt the Binax, which was a good test because these other guys could come to market because there were no rules. And so the point is that in this next pandemic, and hopefully I won't be around for the next pandemic, that the youngins in the audience can learn from some of this. All right, I understand there's no more questions. Again, Dr. Bob Dannenhoffer, the Public Health Officer of Douglas County. Thank you so much for watching and sticking with this. We're doing great in Douglas County. I think if we get a bunch more people immunized, we continue to wear masks and do those things, we really can bring this down so that by the 4th of July, we can start on, we can have a half shell, we can have a fair, we can have a Pepsi float, we can have all those kind of things, which are so great of Douglas County in the summertime. Still not sure how we were going to do graffiti, but I think it would be a shame if we didn't do something for graffiti. Maybe that we line people out more. That'd be perfectly fine. These are cars, they can drive further than that. You could imagine instead of having the 12 blocks that they do, they go 40 blocks, and this allows now people to be more spread out. That would be perfectly great. It'd be outdoors, it would be safe. These cars might actually be driving a little bit faster, and that might actually be a better thing for both the cars and the people around. So again, we're asking people to be safe, to be kind, to be to really work with each other, because I think I'm seeing a way out of this if we just work together for another few months. Again, thank you so much.